tell us. Oh dear, I don't know how to get rid of got it.
We're live.
Okay, hold on. I got it.
Got it.
Let's see, got it. Okay, we are live. Welcome everybody. I'm Allison Clarkson. This is our unusual hybrid Senate Democratic Caucus gathering. It is the Ides of March, so we all have to beware and careful. Today we have, you always have to be careful around us anyway. So this morning this afternoon, we have three big and interesting issues that we're going to be addressing and getting updates on. Senator Hardy's going to begin with the weighting study and the weighting bill. Then we're going to move to big picture economic development and what's coming out of this committee. We're in Senate Economic Development here. And then we're going to go and welcome Jessica Holmes and Robin Lunge from the Green Mountain Care Board. We're going to talk about global budgeting and healthcare reform. So Ruth, Senator Hardy, would you take it away with explaining what work we're doing on the weighting of pupils?
Thank you. It's a caucus. You can join us.
And excuse me, caucus members, we need to mute if you're not talking because it's complicated having many of us in one room. Thanks.
Okay. Oh, wait, this is gonna, I'm sorry, we're just a second. Okay, hopefully this works. We have multiple screens and we're in the finance room and there are multiples of us in here. So good afternoon, everyone. I am going to talk to you briefly about the pupil weighting bill. Oh, Mark. Okay. I
think you're fine.
All right, I don't know if this is, it's not gonna work. Sorry. We have multiple people in the room and it's like a technological nightmare. But okay, pupil weighting. Okay, so pupil weighting. The bill does not yet have a bill number, or it might, but I don't know what it is. But it was voted out of finance last week. As senators will recall, the legislature requested a report, a study actually that was done by a team of researchers at the University of Vermont and the Rutgers University to determine whether or not the weights that we use to count students in our school funding formula were accurate. Under current law, we have a weight for students living in poverty, students who are English language learners, and high school students, and also pre-K students, but those were not included in the study. So the study came out in December of 2019, and the basic conclusion was the weights were no longer accurate. It wasn't clear whether they were ever very accurate. They were done a long time ago, pre-Act 60, which was the big act that came after the Brigham decision in the late 1990s to create a much more equitable funding system in Vermont. So the weights are really old is basically the point there. And so the study recommended updating the weights and provided a number of options to do so. So December 19, 2019, as you all know, several months later, the pandemic hit and we were not able to really act on the study. So last session, we created a task force, the pupil weighting task force, which I co-chaired, and with Representative Kornheiser in the House and Senators Perchlik, Brock, and Hooker also served on that task force. And we did a very, very deep dive into our school funding system during the off session and really looked at the report and looked at a lot of other data and really tried to understand all the interaction effects with our school funding formula. It's extremely complicated. I have 10 minutes, so I'm rushing through all this. And I hope it goes without saying that I'm happy. In fact, I love to talk about this stuff. So anybody who has questions, please come and find me, and I will happily talk to you about it ad nauseum. So what the pupil weighting task force recommended, we came up with a report that we issued in December, and we made a number of smaller recommendations and then two sort of options for moving forward. One is to either update the pupil weights or to adopt what we call a cost equity formula. In the bill, the Senate bill that passed out of finance last week, we went with updating the weights. And I want everyone to know that these are the weights that were calculated, in fact, recalculated by the same team of researchers who did the original pupil weighting study in 2019. So these are not, they were not our weights, the task force, they were the weights of the researchers. So we, in this bill, adopted those weights, and they are weights for, updated weights for poverty, for English language learners, for high school students. It also adds a weight for middle school students and for rural districts based on population, 3 levels of population density, and then small schools in rural parts of the state based on 2 different sizes of schools. So we, in the bill, we updated those weights, and I'm happy to tell you anybody what they are if they want. And then we included a new poverty measure. Currently, the poverty measure that's used for funding schools is the SNAP, or the food stamp, previously known as food stamp benefit measure. What the bill does is actually use the free and reduced lunch price measure. They're both set at 185% of poverty, so it doesn't change that. But the free and reduced lunch is actually a more accurate representation of the number of kids in school who are living in poverty. And it's a school-based measure, so it's more relevant. And then we move to, in the bill, what is called a universal income declaration form, which is something that would be required of all school districts to produce. And AOE would work on creating that form with school districts. So those are the weights portion. For the English language learners, many of you know that this is the area that sort of created the most passion out in the field, shall we say. What we ended up doing was a sort of a compromise, and we, the Finance Committee worked with the Education Committee. The Education Committee sort of took this issue on. The Pupil Weighting Task Force had recommended a pure categorical aid for English language learners for a number of reasons that I'm happy to tell you about. But what we ended up doing in the bill is a compromise where we use the weight for all school districts, and then we have a little mini categorical aid grant on top of the weight for districts that have a very few number of ELL students. The majority of districts in our state have very few ELL students, and the weight does not provide them a significant enough amount of taxing capacity to raise funds to actually support an ELL program. So this little mini grant should give them enough money on top of the taxing capacity provided by the weight in order to support an English language learner, instructor, or teacher for the few numbers. So for 2 or 7 or 19 ELL students. So it's under 25 ELL students would get a mini grant. So that, and then there's stronger guidance for school districts on what should be included in an ELL program. That's basically based on federal requirements that are already in effect, but this codifies them into state law to reinforce the requirements for ELL for all districts. This new sort of the new weights would phase in over a 5-year period. So there would be a 5-year rolling average of equalized pupils for each school district. So it would phase in the weights slowly so that the impact would be mitigated, particularly for districts that would have a large increase in their taxing capacity or a large decrease in their taxing capacity, so they don't get hit all at once. It would also suspend the spending threshold and also suspend some other things in the interim, because districts will have vast changes, or in some cases vast, in some cases small changes in their equalized pupils that won't be because they've changed their budget, but because we've changed the weights. So we're trying to, as much as possible, make it easier for school districts with a 5-year phase-in. It would start in FY24, so not this year. It would be the following year because, as you know, school districts have already passed their budgets mostly. It would also create an education fund advisory committee that would include the commissioner of taxes and the commissioner of, or the secretary of education and JFO, and then some other people who are appointed to really sort of keep track of the education fund and a lot of these issues and make recommendations to us, the legislature, on changes that might be necessary. And there's some specific things we ask them to do. But this would be an ongoing thing. As you know, the weights were not changed for a very long time and it was a problem. So this would create a body that's overseeing and making recommendations on changes to our school funding formula. There is also an audit at the end of the phase-in, and so in FY29, a fairly significant audit that would basically hopefully answer the question is, did this work? Did changing the weights make our school funding formula more equitable? And more importantly, is it leading to better outcomes for the students who are impacted and targeted by the weights? So students in poverty, ELL students, et cetera. So that audit would come in FY29 and it has certain things that should be required in it. And then finally, the other big thing is that the bill provides 6 positions for the Agency of Education. With a funding change this significant, the agency really needs more staff in order to help school districts implement this, to analyze it, to make sure we're getting the right data, and also to provide better support for ELL students, which is something the task force found, is that there needs to be more capacity at the state level to provide guidance and support for districts for their ELL. So those are the highlights of a very complicated bill. I will be trying to get together a 1-page, 2-page summary for everybody, and AOE and JFO are working on a district by district printout of the bill as passed out of finance, so you can all see what happens to your districts. And again, I'm available to talk to any of you who want more details on the impact of this for your districts.
Right.
Thanks, Senator Clarkson.
Thank you, Ruth. That was great. That was a very complicated bill that's taken many years actually in the making, and you have done great work. Are there any questions for Senator Hardy at the moment, or because I think in the interest of time, we're going to go, and I would encourage you to get questions to Senator Hardy as she suggests, right? Go straight to her. So in the interest of time, I see that Jessica and Robin have joined us. So I'm going to go to Senator Sirotkin to give us a very high overview of sort of some of the big meaty things that we're investing in our economic development bill. Take it away, Senator Sirotkin.
Okay, thank you. So this is our omnibus economic development bill. It's probably about 70 pages long, and it falls into about 11 different programs. We start out, and I won't go into this level of detail or anything else, but we start out with the purpose section, which is the purpose of this act is to address the negative economic impacts of COVID-19 on Vermont's economy, employers, workers, and families, while simultaneously leveraging opportunities to grow Vermont's economy. The 11 sections, I'll just give you sort of the titles, and then I'll go into a little bit more detail on each one very quickly. The first section deals with the remote and relocated worker program, tweaking that to make it more palatable to all sides. Then there's a relocation and recruitment initiative that the governor has proposed in the Department of Marketing and Tourism. Then we are reconfiguring the capital investment grant program, which was the $90 million program that the governor had suggested last year. We only spent $10 million of that so far, and we're going to be having to pare down a lot of the monies on all of this. Then the fourth section is the VITA short-term forgivable loan program, which is the successor program to the economic recovery grants, which were undersubscribed this year. Then we're reloading the project-based TIF program, which had passed the full Senate by a wide margin in the past, but didn't make it through the House last year. We're looking at a study on the Vermont Film Commission, and we are reloading the minimum wage bill that was vetoed by the governor. It's in a different context, certainly in the climate we're in now. We're also establishing a COVID-related income replacement program, which helps a lot of people in the past and future in 2022 who suffered from loss of income because they had to leave their job beyond their paid sick time. We're doing a paid medical and family leave task force along the lines of which we did with minimum wage at one point. And we're also reloading or trying to reconfigure the $25 UI supplement that was passed and signed into law, but because of federal conformance issues, never got to the people. We may also talk about an online sports betting task force, very similar or identical to the one that the Senate passed 2 years ago. So those are the highlights. I'll give a little bit more meat on each one. The remote and relocated worker program. There's been some criticism that people could actually be here and relocated before they got their grants, and that might be a formula for abuse. So we're going to fix that. And we're also, the House insisted on limiting the workers, the professions that could qualify for this. That turned out to be very disadvantage to the program itself, and a lot of people that wanted to come here couldn't qualify because they were in the wrong professions. The Marketing and Tourism Department wants to start a relocation and recruitment program at local regional levels to get people here, more people to come here and stay here, and also do economic development promotion. The money that they have right now is just available for tourism. So this would broaden their scope of work. The Capital Investment Grant Program, again, this is the $90 million program that the governor had suggested for transformational projects, big projects that would change regions. The federal government in some ways put the kibosh on that. So we're reconfiguring how we can get some money out the door for capital investment programs, delayed improvements and maintenance programs, and help businesses in that regard. The VITA short-term forgivable loan program is a successor to the economic recovery grant program, which because of some of the restrictions we put on the program and otherwise has had a very small uptake. We had put in $30 million and only $4 million has been applied for so far. So we're reconfiguring that and moving it to VITA, which we are hoping could better target the money and get it out the door. The project-based TIFs, I think you're all aware of. We passed that, I think, several times, and it can't get through the House, but we're reloading that so that smaller communities can apply for TIFs without all the administrative burdens and get that going. The Film Commission is, we don't know yet whether it'll be a study or how it will take a form, but we think we're missing some opportunities there, but we don't know how far we can go. It will cost virtually no money, but will mandate a revisiting of that sector. The minimum wage bill is $15 by 2024, which is really not an effort to raise the minimum wage as opposed to protect the inflationary factor on the minimum wage. If we don't do this, then you can see our $12.55 going up next year to $12.70, which nobody is paying right now. So that advantage of inflation has no real impact. So we're going to put that on the bill. COVID income replacement program is important. A lot of people, just like businesses, are looking for recovery money and capital improvement money because of their losses over these last 2 years. A lot of people have gone out of work and lost income because of Omicron, and we're trying to give them a little bit of help. It's very similar to the federal program that people were unaware of that expired. That was essentially a paid leave program for a few weeks for people who are out of work due to COVID. It's a continuation of that. It's structured almost identically to the hazard pay program of the last session. And we've had the commissioner in from banking and insurance. He says it's pretty easy to administer to get the money. It's a voluntary program. The employers have to sign up to get the money to pass it through to the workers. The paid family and medical leave task force is structured very similar to the minimum wage task force we had about 5 years ago. Three senators, 3 representatives to study and update previous studies on paid family leave. As Senator Clarkson and I both say, there couldn't be a better poster child for the need for paid family and medical leave than what has happened to us over the last 2 years with COVID. So we want to launch that as well. The UI $25 supplement, it was signed by the governor. The feds came in and said there were some technical defects, and the $25 supplement never got out the door to the workers. It was a big deal last year, and we want to find a way to just make that happen. And then the online sports betting, if we do that, will essentially be the summer study we passed 2 years ago in the Senate, which the House didn't consider. So those are the pieces at this point. We hope to vote it out tomorrow.
Thank you. Thank you, thank you. And again, just as we did with Senator Hardy, I would encourage you, if you have questions of us, please ask us, but ask us individually, I think at this point, just given how tight our time is right now. So to tee up Jessica and Robin, thank you, Senator Sorokin. It was great. That was great. That was terrific. To tee up Jessica and Robin, I'm going to ask Ginny, Senator Lyons, to please introduce our presenters.
Thank you, Allison. And, thank you for bringing Jessica and Robin in today. As our committee has been looking at healthcare transformation, we hear about out-of-pocket, we hear about co-pays, we hear about unexpected bills, we hear all the problems that are going on with our hospitals, with our primary care providers, and trying to maintain continuity of our system of care. But as we begin to work in our committee, it becomes an exercise in going through the weeds. And we've had reports from our consultants from the Health Reform Oversight Committee and consultant from the Accessible Affordable Healthcare Task Force from last summer that I co-chaired. And we also have had reports from the Green Mountain Care Board, all of which lead us to trying to build some alignment within our system and to build a system of care that Vermonters and we can understand. So, as we work in our committee, it was really, really refreshing to hear from Jessica Holmes of the Green Mountain Care Board and her comments on our healthcare system. She really allows for us to build a context for understanding the work that we're doing, which is why I am so pleased to welcome Jessica. Thank you for being here. And also Robin, thank you for backup. I don't know that either one of you need it. But so Jessica, I just would ask you please to go ahead and share your information with us, because I think it is so refreshing. Thank you.
Well, thank you so much for the invitation. And just by way of a brief introduction, I am one of the members of the Green Mountain Care Board. I am also an economist by training, and I teach at Middlebury College. In fact, just left class and I'm sitting in a small room outside my classroom. But I'm happy to be here, and I really appreciate the invitation to speak about the hospital sustainability efforts that are outlined in S285. And I want to say that I speak as just one board member, but one who has been involved in these hospital sustainability efforts since the beginning, and as someone who is passionate about continuing to improve access, cost, and quality of healthcare for all Vermonters. Vermont is an amazing place. We have committed state leaders, compassionate hospital leaders and healthcare providers, and strong communities dedicated to improving our healthcare system. That's why we're all here. But it's important to know we cannot kid ourselves. If we really want to improve Vermonters' health and make healthcare more affordable, we need to change how we pay for healthcare, and we need to look for innovative ways to ensure that our healthcare delivery system is designed to maximize access and quality and minimize costs. Significant payment and delivery reform efforts will require resources, time, and frankly, the leadership and the courage to overcome the inevitable resistance to change. It's human nature to resist change. It's an emotional response. It has a name. It's called status quo bias, and it's a strong preference for the status quo. So any change from the status quo is perceived as a loss. But Vermonters are not winning right now. Healthcare is not affordable for many families. Many Vermonters don't have access to primary care, dental care, and other essential services. Our mental health care system does not come anywhere close to meeting the needs of Vermonters. And the stories we hear about people's struggles to find care are truly heartbreaking. And as populations decline and hospital volumes shrink, average costs are going to rise and the quality of care may be compromised. Our hospitals are already struggling financially. Expenses are rising faster than revenues and margins are shrinking. In response, some hospitals are beginning to reduce essential services like pediatrics. Both Brattleboro and Northwestern recently shed their pediatrics practices. This is devastating news. Investing in our children's health is investing in our future. Medicaid and Medicare reimbursements are not keeping pace with inflation, and the current strategy of relying on commercial rates paid by the privately insured to cover these rising healthcare costs is no longer viable or sustainable. Even if the Green Mountain Care Board approved higher and higher commercial rates for hospitals, there are not enough privately insured Vermonters to afford them. If we don't change course, and soon, we're going to see more uninsured, more underinsured, more free debt and charity care, and employers reducing health benefits. We will see families facing hard choices between paying rent or buying medicine. And as access is compromised and essential services like pediatrics and primary care and mental health are dropped, population health will inevitably decline. So we're not on a sustainable path. And if we don't act now with intentional payment and delivery redesign, market forces are going to take over. Some hospitals may go bankrupt, close, or come to the state for emergency relief, as Springfield Hospital did, asking for and receiving millions of state dollars to keep its doors open. And it will be those hospitals serving our most vulnerable patients that will fall first. Other hospitals will divest of essential services, and it will likely be the least profitable services like primary care and mental health that will be shed first. In fact, it's already happening. So we need to act swiftly and courageously. As you will see, S285 earmarks $4.5 million to support the Green Mountain Care Board's work necessary to ensure a sustainable, high-quality healthcare system. $4.5 million may sound like a large investment, but think of the cost of doing nothing. S285 offers an important path to hospital sustainability and improved health for Vermonters. It supports both the design of a new value-based payment model that relies on fixed payments, also called global payments, and delivery system transformation. The goal of fixed payments is to ensure that hospitals have predictable revenue streams that can cover the cost of delivering high-value services in their communities. Hospitals will no longer have to chase volume to maintain sustainable margins. Instead, with a predictable revenue stream, they can redirect scarce resources to those services that have the greatest impact on Vermonters' health, like primary care and mental health. They can invest in the social determinants of health, which often have a greater impact on health outcomes than medical care. And they'll be incentivized to keep patients healthy and out of the hospital. Fixed payments have been the recommendation of several consultants and policy experts who have come before the Green Mountain Care Board. Global payments are also the approach advocated by Donna Kinzer, a consultant to the Vermont legislature, and as well as the American Hospital Association's task force on ensuring access in vulnerable communities. So payments are the path to both better health for Vermonters and greater hospital sustainability, particularly in rural areas facing declining populations and low volumes. But thinking about how to set and operationalize these fixed or global payments, inclusive of Medicare, will take actuarial expertise, careful planning, stakeholder engagement, and negotiation with the federal government. Hence, that's $2 million of the $4.5 million ask in S285. But it's critical that this payment reform be done in parallel with a patient-centered, community and provider inclusive redesign of our healthcare delivery system. You want the fixed payments to support a system that is designed to improve Vermonters' health at the lowest cost and the highest quality. Maintaining Vermont's current infrastructure means struggling to pay high fixed costs in the face of declining populations and spreading our already strained workforce too thinly. With our very real workforce shortage, we cannot afford to have an inefficient system. Some areas of the state are seeing populations decline, and technological innovation is moving care out of hospitals towards outpatient settings and even into the home. Our current payment system relies on patient volumes to keep the lights on, but those lights are starting to dim as populations decline, patients bypass their small local hospitals to seek care at larger centers, and new delivery models like hospital at home, telemonitoring, and telemedicine gain more traction. And we really can't ignore that Dartmouth Hitchcock is building a large new bed tower on the southeastern border of the state. This expansion is likely going to attract both workforce and patients, which will exacerbate workforce shortages in Vermont and decrease occupancy rates for hospitals already struggling to cover their fixed costs. So the 2.5 of the $4.5 million ask is to support the challenging work of delivery system transformation. This effort will be time-consuming and data-driven and will require working collaboratively with health systems design experts and local communities to design and support a system that best meets the needs of patients in each community. These community conversations will likely have three components. The first is to build a shared understanding of the current state, right? So making sure that there's a shared understanding of the conditions of the local hospital. What's the financial hospital of the hospital look like? What are those margins? What are the relative prices and the relative costs at that hospital? What are the quality measures? What are occupancy rates? What are trends over time? What is the health status of patients in that community? Where are the unmet needs? Where are residents seeking care, at the home hospital or elsewhere, and why? What does access to essential services look like in each community? Primary care, mental health, substance abuse treatment, dental care. Are we seeing evidence of avoidable hospitalizations in a community that could be prevented through more timely access to preventative primary care? The second component will be building a shared understanding of the future state. What trends are on the horizon and how well is each local healthcare delivery system prepared for those trends? What headwinds should each community be prepared for? So for example, is the local population shrinking or growing? Is it aging at rates faster or slower than the rest of the state? Is the hospital going to be impacted by the Dartmouth Hitchcock expansion? How will that expansion impact the local hospital's occupancy rates? Will it exacerbate workforce shortages as workers are drawn to higher wages at Dartmouth Hitchcock? And the federal government is moving to payment models that hold hospitals more accountable for costs and quality. Are hospitals ready? Where does the local hospital stand on measures of both cost and quality? And then the third component will be creating opportunities. What is possible? This is where we would really benefit from the experience of health systems design experts who have successfully facilitated system redesign and found innovative solutions to meet community needs. So how might the community's unmet needs be better addressed? Do we need to shift more resources towards more primary care and early prevention? And if so, how do we do that? What innovative models of delivery have proven successful in rural areas? How might shared services and satellite clinics and centers of excellence improve health outcomes and lower costs for Vermonters? These are the types of questions and conversations that we would like to have with our communities. And S285 would allow the Green Mountain Care Board to contract with experts in both health systems design and also experts in community facilitation to help us package and present complex data specific to each community so that it's really understood by community members, prepare for and facilitate conversations with community leaders and stakeholders. We want to engage hospital leaders and trustees, providers all along the care continuum, both inside and outside the hospital walls, community leaders, employers, the Healthcare Advocates Office, and patients, of course, patients. And these conversations have to occur at both a local level and a regional level. And we're hoping that legislators will help us identify key stakeholders and actively participate in all of these conversations. We would need to contract with experts to design and facilitate that community process so that it's inclusive and the dialogue is meaningful. And then we need to work with health systems design experts to help communities brainstorm what is possible. How might we improve access to essential services? How might we improve quality? How do we better reduce the growth of costs so that healthcare is more affordable? So we have a lot of work to do. I don't think we can wait. S285 provides the resources and the scaffolding to do that important work. In my mind, the $4.5 million sounds like a lot, but it's a small investment to ensure that our payment system aligns provider incentives with desired health outcomes of Vermonters, that the healthcare delivery system is prepared for the trends that are coming our way, and that it's optimally designed to meet the healthcare needs of all Vermonters, no matter where they live. We're not on a sustainable path. I don't think if we don't act now, market forces will prevail, and we might not like that outcome. So S285 provides the resources necessary to engage experts in intentional hospital payment and delivery system redesign so that our healthcare system is prepared for the headwinds coming our way. It might be the most important investment in healthcare we make. So I want to thank you for your time. My fellow board member, Robin Lunge, is here as well. We're happy to answer questions today. I know time is a constraint, so also happy to answer any questions and follow-up conversations if that's easier and better, more efficient. But thank you for having us today.
Thank you very much, Jessica. That was a whirlwind and so, okay. And Robin, do you have anything to add to this? And then let's open it up for questions.
I'm just here to help with questions.
Okay, great. And our format, just given how we are, is a little awkward, but we're going to ask, we're opening it to questions and we'll see if there are some. So, Caucus, fabulous Caucus. Do we have questions for Jessica or Robin at this point? Shout them out because I can't see you very well. Oh. Okay. Everybody got it. They're quick studies, these senators.
That's great.
So when you talk about global budgeting, can you just describe what that term means? Because it's a very it's a sort of impenetrable term.
Sure, I'll take a first stab at that and Jess can chime in. So there are a number of different ways that states have approached doing a global hospital budget. Maryland is one state that has implemented this and has had it in place for a long time. Pennsylvania took a different approach that was a payer by payer. So really what the goal is to have a payment methodology so that the hospital is getting a fixed amount from the payers that it contracts with. So the insurance companies, Medicaid and Medicare, in order to build essentially a true budget, the way that you or I would think of a budget. We have a good start on that with our hospital budget process, which has been in place for a long time. But having spent the last 6 years working within that regulatory structure, there's some definite improvements to make it operate more like a true budget for the hospital. So really what the goal is to have the hospital understand their predictable fixed revenue stream so that they can operate within it and invest in ways that are not tied to the underlying current fee-for-service structure. Jess, do you want to jump in and add anything?
I guess I would just say that through the all-payer model, we've had some success already with fixed prospective payments coming through our Medicaid program, where hospitals receive a predictable amount of money per patient for care delivered to Medicaid patients. The reception that we've received of the Medicaid program has been positive, and hospitals have requested that when we're thinking about our next agreement, that we also move towards more fixed payments from Medicare. So in part, this is all along the process of trying to move away from a volume-driven payment system where hospitals are chasing volume and receiving money for every service they provide, to a system more like the current Medicaid payment model, where hospitals are receiving a fixed payment to deliver care for a subset of patients. And we want to do that across all three payer types: Medicaid, Medicare, and the commercial sector. It allows for more flexibility for hospitals to allocate resources in ways that actually have the highest impact on patients' health, versus trying right now to chase volume, particularly volume in high margin areas where they're making the most money. It's not always, like I said earlier, the highest impact areas are in primary care and mental health, but those also tend to be low margin areas in a fee-for-service system. So if we can move away from that towards a fixed payment model, it will allow hospitals to have a predictable revenue stream and allow them to invest more in primary care, preventative care, and the types of services that will have the greatest impact on patients' health.
So if this is all enacted and goes according to Hoyle, how long will we see, how long does Vermont have to wait if we implement this all? How long will we see results? How soon will we see costs being reined in? I mean, what's our time frame on this?
Yeah, so I think I would expect that this is a long-term project. So, for example, we've been estimating that the community engagement process would take probably about a year. We would simultaneously be working on the regulatory and payment design. But I think in order to do this, because it is a big change, we need to be careful and move in a very intentional way. So I do think that I would expect for the change to actually be implemented would take a year or 2 years, and that you would then see some of the movement after that. At healthcare, everything is, quite frankly, very slow, much slower than any of us would like. Vermont has seen some cost containment in the last 6 to 10 years, I would say. So our average hospital spending has been between 3% and 4% over that period of time, which in healthcare is quite low. So I think we've been successful to date, but in order to truly see a shift to focus on the types of care that I think we all would like to see, I think this will help accelerate that. What did I miss, Jen?
Robin and Jessica, would you mind commenting on the, as global budgeting goes forward and fee-for-service service volume decreases, we will also be seeing some increased quality of care. Can you talk a little bit about that? Because I think that's the patient outcome benefit that is consistent with what is planned in S285.
Absolutely. I think to Jessica's earlier point about fixed costs, in order to maintain an infrastructure, there will be a certain amount of fixed costs in the system. So I do think, to Senator Lyons' point, that improving quality and access to essential services has to be a key focus here, and a key outcome that we're focusing on. We do tend to, as a state, think about cost containment as a singular goal, but I do think that what we're starting to see in some of our systems is the need for increased access and improved quality. Jess, do you want to chime in?
Well, I was just going to say, I think as you move from a fee-for-service payment model towards what we call a value-based payment model, which actually is ensuring that the payments are aligned with what we want to see in terms of population health, lower cost and higher quality. As we hold providers accountable, in some ways, this is how we think about it, for cost and quality, they're going to invest in the resources that are going to basically improve population health. So we're going to see a shift in investments towards more primary care, towards more mental health, towards more of the services that we know have the highest impact on patients' health, because they'll have the resources to be able to do that. And so I think in terms of the timeline, you're going to start to see the shift in investments and the shift in resources soon under these payment models. And then the longer term benefits will take a while to materialize. Obviously, we have long-term, we're looking at the long run here in terms of improving population health.
I hate, as you can see, some of the rooms are leaving. Our committees are beginning at 1 or 1:15, and some of them are beginning at 1. So people will peel off. But Jessica and Robin, thank you so much. This was terrific. Anyway, thank you very much. And thank you for everyone who's joined us out there in internet land. We appreciate your joining us, and thank you for moving us along in our understanding of what we're taking up in S285, which we take up this week or next. Thank you very much.